Okay. Good morning, everyone. My name is Arissa Amnuaychottawe. I am a postgraduate student from the Aesthetic Restorative and Implant Dentistry program from Chulalongkorn University. Today, I would like to present my research to all of you. The topic is effect of operator experience on the accuracy of single implant position with computer-guided surgery appellate study. My advisor is Associate Professor Dr. Adipan Pimkhawkham. Nowadays, dental implants are widely used to replace missing teeth. It is accepted that dental implant therapy is a predictable treatment option for tooth replacement. The recent philosophy of prosthetic-driven implant placement has developed to optimize the aesthetic outcome with optimal loading condition and good access for cleaning. Placing implant in the anterior zone of maxilla needs a more critical accurate because it's in the visibility area, especially in patients with high smile eye. There are several factors which affect the predictability of aesthetic outcome of an anterior restoration as shown in this slide. In the past, freehand approach is commonly used. However, in recent years, the customized radiographic and surgical templates have become essential for transferring the virtual plan to clinical situation because implant placement through the guide allows a more accurate than freehand insertion. The computer-assisted implant surgery or CAIS is made by using cone beam computed tomography or CBCT and CAD/CAM technology. A static surgical guide is used to transfer the planned implant position to the surgical site. The fabrication of computer-generated guide starts with taking a CBCT scan with a radiographic template which simulates the preoperative prosthetic design. The DICOM file and CBCT images must be transferred into the implant planning software. Then evaluate the plan, the position, and the size of dental implant. After plan is complete, transfer the data to the milling center to fabricate the surgical template. And after that, evaluate the surgical template to ensure the proper seating. The template is then fixed in the patient mouth and used to guide the surgeon in placing an implant. The advantages of the static CAIS include it offers an accurate implant placement, shorter surgical time, requires less invasive surgery with a consequent decrease in postoperative discomfort. However, the limitation of the static CAIS are that the guides then also limit the ability to irrigate the drill during the osteotomy process. Moreover, in case of limit mouth opening and implant placement at the second molar, the use of static guide is difficult due to the limited accessibility. Furthermore, it does not allow any changes at the time of surgery, and the deviation are observed between plan and postoperative outcome. There are still controversy about the effect of operator experience. The study of HINFAS in 2012 and Cushion in 2013 conclude that the surgeon experienced statistically significant affect the accuracy in implant placement. On the other hand, from the study of Rumjarasan on 2015, they reported that there were no significant differences in the angular and linear deviation between two groups in all aspects except for apicoronal direction. Moreover, Park and Arthur in 2017 revealed that there were no significant differences in any of deviation parameters between experienced and inexperienced groups. Consistent to the study of Cassetta and Belladini in the same year, the results show no significant difference in coronal, apical, and angular deviation. So the aim of this study was to determine the accuracy of implant inserted by experienced and inexperienced operators. And the null hypothesis was that the correctness of implant installation by inexperienced operator does not differ from the experienced operator when using a step-by-step computer-guided surgery. 6 inexperienced operators were included from fifth-year dental students who received an implant lesson about computer-guided surgery but did not have any experience in placing dental implant. Another 6 experienced operators were recruited from dentists who graduated from the Aesthetic Restorative and Implant Dentistry program and has placed more than 20 implants with no less than 3 years of experience. Maxillary model with single missing space at the right central incisor were used for the study models. The 3 bone type was used to representing the maxillary bone, and the planned implant was a Stallman bone level taper implant, size 3.3 by 10 millimeters, and the surgical guide template fabricated by 1 template to 1 model protocol were used in this study. All models were scanned by CBCT with 3D iCAD machine and 3Shape 3-os intraoral scanner. All the scan data were transferred to 3Shape Implant Studio, which was used to designate the position of virtual implant. The optimal position of the implants was adjusted manually by one dentist. After dental implants were planned, the digital dual guide were designed, and this information was sent to dental laboratory for surgical template fabrication. Before the surgical procedure started, the fit of the surgical guide was verified via inspection and adjusted manually. Implant placement was performed by experienced and inexperienced groups. One operator placed 1 implant. A step-by-step computer-guided surgery was explained to each operator. Post-operative model scans with the scan body were taken for all models, and the STL file of planned and placed implant were superimposed and measure the deviation by 3Shape implant compared to 4 parameters used for outcome measurement are shown in this table. The coronal displacement is the 3-dimensional distance between the center of planned and placed implant platform. The horizontal displacement is the distance between the center of the implant platform of the horizontal axis. The depth deviation is the distance of the longitudinal axis between coronal center of the planned and placed implant. And the last one is angular deviation, which is the angle between virtual and actual implant axis. The statistical analysis was performed with SPSS software, and all data were analyzed and compared using independent t-tests. The mean and standard deviation of all measurements are shown in this table, and the analysis did not show any statistically significant differences in all deviation parameters between 2 groups. So that the result of this study support the agreement of the null hypothesis with each. The level of the operator experience would not affect the accuracy of implant position. The mean amount of coronal and horizontal and depth deviation found in this study are in the range of similar investigation. So the result of this study confirmed the conclusion of all previously studied that the effect of operator experience had a limited influence on the accuracy. On the other hand, the mean amount of angular deviation of this study was less angular error than found in other similar studies. The less angular deviation may arise from that this study was performed only single implant on the anterior tooth, and the study used a tooth-borne surgical guide template, which is easier to control the stability of the guide and accessibility of the drill. There are clinical reports mentioned about a learning curve, and there is still an unclear conclusion about the chronological changes of surgeon placement skill. WhatsApp evaluated the factor surgeon as potential reason for deviation and found a learning effect over the time in buccolingual and depth deviation. Moreover, another study by Valente and friend in 2009, they did not find a clear learning curve except for angular deviation and depth deviation. So that this study used 1 operator to place 1 implant to eliminate the influence of learning curve. The absence of a significant difference in positioning error between two groups seemed to propose that the static surgical guided system could improve the accuracy of implant placement, especially for the operator with limited experience in placing implant. However, limitation of this investigation were that it was an in vitro study operated under control condition without limit mouth opening and tissue interaction, and may consequently underestimate an error. Besides, this study did not consider and compare the time spent in the implant placement process between two groups. Another limitation was this study was a pilot study performed by a limited number of participants, so these experimental results might not be able to refer to clinical situation. Within the limitation of this study, we can conclude that the operator experience had no significant effect on the accuracy of single implant placement under step-by-step computer-guided surgery. However, further investigation with a larger number of clinicians are recommended to confirm the result. Thank you all for listening, and it was a pleasure being here today. Does anyone have any question?
Sorry, I have a question. Can you hear?
Yes, please speak.
Okay. According to your study, there are many today there are many brands of guided surgery system in our country. So do you think the result of your study can apply to other system of static guided surgery?
Okay, in my opinion, this experimental result may not able to refer to other guide surgery system because each guide has their own concept and their own different component. But I think the different guide surgery system is recommended to further investigation.
Thank you.
Are there any questions? Okay, in this study, it is concluded that when using the computer-aided implant surgery, the accuracies of implant position between the operator with or without experience is indifferent. That's right?
Yes.
Okay. In this case, do you think that it is better for the dentist who doesn't have the experience in the fields of implant in dentistry should be used computer-guided implant surgery or conventional implant surgical guides before placement of implant? You think so? You think?
Yeah, yes, I think if in the limited experience or no experience in placing implant operator, I think if we can use the static surgical guide surgery to place an implant is more accurate and useful more than freehand insertion.
Yes, thank you. Okay, thank you, Arissa, for the good presentation and the interesting research. Okay.
Thank you.
Thank you.